To ask Dr. Chandrasekhar Chawan to go ahead with his presentation.
Thank you very much. It was really wonderful morning for me here in Orlando, listening to all these top-notch people. Again, Dr. Muscathy's talk was wonderful. That reminded me of my time with him. I used to work with him, and I've seen all those, gadgets, and wonderful. So today my talk is on current updates on myopia control. I'm going to take you from basics to a little higher so that it can help newcomers as well. So yes, now everybody knows about pandemic and epidemic because of the COVID, but due to this COVID pandemic, the childrens are at home and not going to school, and they're spending a lot of time on close work, tablet, screen, mobile phones, and it is going to be a big concern. It was a big concern anyways, but now it's going to be more because global estimate shows that prevalence of myopia is going to increase from 20% to 50% in next 30 years. So the COVID pandemic is directly linked to myopia progression in a way now. So many people ask, is it a very serious issue? Yes, axial length elongation is directly related to eye morbidities, like increased risk of glaucoma. If you have the study shows about -3 diopters, there is a chance of 1.65% of getting glaucoma at an early age. And if it is more than -3, then it is 2.46, and it keeps on increasing the percentage. If myopia is less than 5 diopters, the myopic maculopathy is 0.42%, whereas if it increases beyond -5, then the prevalence is almost 25%. So, which is, sight-threatening issue. Retinal detachment, as you know, it is, very serious issue. So here is an odd ratio of from -1 to -3. Odds ratio of getting retinal detachment is about 2.2, whereas -3 to -5, the ratio goes to 9.7, and beyond -5 to -7, 40%. And unfortunately, over -7, it is 126%. That means you can guarantee that patient that he's going to get retinal detachment. So he has to be, more careful. Now compare that to hypertension. So hypertension is directly linked to cardiovascular disease, right? That everybody knows and accepted. So, you have to maintain your blood pressure, otherwise your odds ratio increases of getting cardiovascular disease. Thanks for the slides from Dr. Thomas Wyszewski. Again, smoking is directly related to strokes. So similarly, the myopia is directly related to eye morbidities. So it is very serious issue. But if you can control at least 50% of myopia progression by any means, you are drastically decreasing the risk of glaucoma by 67%, by getting cataract at early age by 74%, retinal detachment by 98%, and maculopathy by about 99%. So that's why it is important to act now and try and control the myopia progression in children. So many times this is seen that, when the parent comes, because parents are in charge and they will say, hey, I have myopia, but, I'm doing fine. I did LASIK or, did a lot of refractive surgeries and I'm fine. Nothing happens. But, most of the time, of course, then they will say that, let us wait for a year or so and see what happens. Sometimes they'll say it's very expensive treatment that you're offering, or they will say, hey, he's just a child, he cannot handle contact lenses. So the answers to that is when the patient comes with a child of about 6 years to 10 years, the patient himself, the parent himself is in his 30s. So he's just waiting for that time bomb to click, because all these morbidities will start showing up about the age of 50, 55 years. So he's not yet gone there, and that's why he's presuming that nothing is going to go wrong. So it's our duty to educate them what is the science is. When they say, okay, let us wait for some time, by then even in 1 year the actual length has increased and it has already put the child on a risk path. The expense now, okay, you're saving some money by just giving them glasses, but when they get glaucoma, when they get cataract, when they get retinal detachment, imagine how much money you are going to spend at the cost of losing the eyesight. So here is an example of an image shell of uncorrected myopia. I think you can see this green. So, it's myopia. It's the light, the image is forming in front of the retina. So understand this concept of hyperopic defocus. So this is the hyperopic defocus, which is out of this retinal image, and this is the one which is sending signal to the brain to grow. So when you correct this myopia with glasses, you're correcting a distance vision, but the image shell at the periphery, this image is blurred and it is causing a hyperopic defocus. So that sends a signal to the brain to grow in that direction. And if you use a dual focus device like multifocal contact lens or anything else, then what you're doing is you're giving them a distance vision, but at the same time you're bringing this defocus to myopic defocus in front of the retina, and this is the signal that brain will catch and say, hey, instead of growing this way, let us grow inward. Of course, it's not possible to shrink, but it will put a brake on myopia progression. So here is my bold statement: single vision correction equal to myopia progression. This is what happens when you give these single vision correction glasses to these children's. What you're doing is you're giving them distance correction, but you're causing a hyperopic defocus at the peripheral retina. And at the same time, UV light is cut off from the glasses. And that is what you're pushing that child in more and more myopia progression. And Dr. Earl Smith, unfortunately, he's no more with us. He's a fantastic research scientist. He has published a lot of animal research that has given us a lot of, insight into how this works. And his research with animals and chicks and kittens, and there are a lot of research going on around the world now. So what he has done, he has controlled the lights entering on the retina, and you can see the actual deformation or the progression of the eyeball elongation. And that has given us a lot of insight, and a lot of research went into that, and a lot of new concepts are coming up in the market now. So dual focus vision correction is required to have myopic defocus on peripheral retina that will send signals to brain to stop elongation, at the same time give clear focus on the macula for distance vision. So first thing that comes to our mind is bifocal glasses. People have used bifocal, the D segment downwards, D segment upwards, because that is what glasses are available. Executive bifocal, there is a lot of good papers on this from Canada that was published and shows a lot of good results on myopia progression. But then the children's are not comfortable with this segmented bifocal. Even adults are not comfortable with that, so people use progressive addition lenses. But again, what you're doing with this is only treating half of the retina. The rest of the half is not getting treated. So now new glasses are coming up in the market that will give 360-degree of correction of plus around the periphery, and that can help myopia progression control. A lot of glasses are in the market now in manufacturing and waiting for to come to the market and to the common people. But the good news is in 2019, US FDA approved this multifocal soft contact lenses, which has a very unique design. So there is a central correction, then there is a plus zone, and then again correction for distance, and then again plus zone. So this is causing a peripheral myopic defocus, and that is going to send the signal to the brain and control the myopia. And very good results are there. The paper shows that from 25% to 72% of myopia progression can be controlled with this. Of course, orthokeratology has been there since many years. And when I used to practice about 15 years back, I never could understand why certain children's number never progressed with when they started on orthokeratology, and some people progress. So nowadays we understand that creating a smaller target zone, gives that plus peripheral myopic defocus, and that is causing the myopia to stop. So there is a lot of research on papers available on orthokeratology. So it works while child is sleeping, and it's reversible. Of course, low dose atropine has been very famous. Started from Singapore, and now it's all over world. And then they started trying to bring it down, the concentration, because atropine, nobody knows the long-term effects of atropine. So 0.01% also as effective as 0.025, 0.5. Of course, there are studies shows that 0.025 is more effective, but there are a lot of studies coming up. And the latest research or latest study says that even 1% atropine put only once in a month is as effective as 0.01% daily. So there are a lot of new information coming up, and it can be used wisely depending on your confidence level and what you feel. So 1% atropine is once a month is the latest study that has come in. And the best part is you don't have to compound it, because it is readily available in the market already. And if you combine that atropine treatment with multifocal soft lenses or orthokeratology, it can do wonders, really wonders. There are a lot of research that shows that. Now, if you use only one modality, because I know a lot of ophthalmologists like to use only atropine and they don't believe in orthokeratology, and a lot of optometrists don't understand or don't believe in using atropine for long term, and so there is a choice you have to make. So when you stop atropine, because atropine usually they will stop after 2 years, and what is seen that the myopia bounces back. Whereas if you use orthokeratology, and even if you stop orthokeratology after 2 years, the myopia will not bounce back, but it will again start progressing from that point in time. So that is the basic difference between both. But if you can combine, it's wonderful. So more than -5 diopters of myopia can lead to sight-threatening conditions at early 50s. So the magic number is -5 diopters. You have to try and control the myopia less than 5 if possible. Of course, the age of onset of myopia is a major things to consider and go aggressively. So if you get a child, less than 12 years, then you know that it is going to be high myope when he's grown up. So you have to be more aggressive in treating such children. Nowadays, I have seen that a lot of children are coming with astigmatism. And though the cause is not known, but the multifocal soft contact lenses which are available in the market as of now are only in spherical powers, and they don't come in toric powers. I'm sure they will come in toric powers also, but as of now, it's only spherical. So here, the orthokeratology can help to control that myopic astigmatism. And so there are now a lot of toric orthokeratology options available. Not now, they have been there since 4 or 5 years. So the Euclid has an emerald toric design that works on topography. You have to provide them topography and they will design a lens. You have Paragon CRT with a dual axis design. Context OK system, E-system has a tag design. Ortho Tool Pro has dual and quad axis design, and Wavelens has dual cord as well as topography. So you have a lot of companies who can help you design your toric lenses. And if you are, want to have all the control in your hand, there are a lot of other software, but this is my favorite software called RGP Designer software, where you can actually punch in the numbers and see what the lens is going to look like. And it also shows the image also, how it's going to look like on the cornea. So it shows what you're going to expect on a fluorescein pattern. And this is wonderful tool that you can have. I'd like to present a case here. This female 16-year-old came to us with 20/30 in right hand, 20/100 in left eye, minus 3.75 with -1 cylinder, minus 1.75 with 1.5 cylinder in the left eye, and these are her case. So I fitted her with a Toric Ortho-K design, Emerald design, minus 3.75 with -1 cylinder and 1.75 with 1.75 cylinders. These are the topographies. You can see the delta K in right eye is 1 diopter, and this is 2.3 diopters. And this is 2019. And of course, we lost 1 year due to pandemic. And then now, last month, I saw her with not much of a change on delta K. And the patient is, you can see the topography here. The delta K not change much, 1.05 to 1.09, and in left eye 2.3 to 2.16. So, patient is amazing. She's happy. 20/20 in both eyes with holding time of 16 hours. So we just replaced the Ortho-K lens with the same RX. This is how the fluorescein pattern looks like on the eye. Amazing. It's really nice to see such patients, and we can, actually intervene and try and control myopia progression. So the key is to start early. Consider parental myopia also as a factor, because the child is going to get at least that much myopia. Then, time outdoors. You have to understand how much time that child spends outdoors, how much time the child works on near work, like, studying or computer or tablets or mobile phone. The lighting conditions in the room and around the room, the food habits, these are all going to play a role in myopia progression. Whenever, the myopia is the disease of axial length elongation. So the axial length monitoring is also important to understand, what your treatment is offering them. And always give multifocal vision correction devices, maybe your spectacles, multifocal contact lenses, orthokeratology, and consider aggressive and combined treatment with atropine as well as multifocal lenses or orthokeratology. That will really guarantee the control in much better way. So here is a simple diagram. Again, this is from Dr. Thomas Wyszewski. Dr. Rob Gerowitz, most of us know him. Matt, Matthew, and Tom. These people have been teaching around the world about how to control and the tricks and trades of the myopia control, and I had the opportunity to learn under him. And this is the slide, like if it is less than about -5 is the cutoff, and age is about 12 years. So when that is the time when you have to go aggressively and use combined therapy of atropine as well as orthokeratology. But if you think that the parents are high myope and the child is going to get myopia, high myopia, then yes, you can start even early. You don't have to wait for the child to grow older. So in summary, understand the how the mechanism of light works, myopic defocus, hyperopic defocus, and this is what you are trying to control with your optical devices. There is a nice calculator online, Brian Holden Vision Institute. They even have programs for teaching you how to go about myopia control, and it's amazing program they have, teaching program. But this calculator is almost free for you, anybody, and you can use that to show the prediction that if you don't control, what is going to happen this is just minus 0.5 diopters at the age of 6. The child is going to get minus 6.75 when he's grown up, about the age of 18. And if you do some intervention, if you try to control, then about minus 3.69 is what you can control with multifocal soft lenses. If you change this to Ortho-K, you will get different results. If you combine, you will get different results. Now, food for healthy eyes: vitamin A, vitamin C, vitamin E, zinc, lutein, xanthanin, delta carotene, omega-3 fatty acid. This is good for everyone, not only child, but everyone. But since the child is growing, you have to consider this, adding into their everyday food, breakfast or lunch. And most importantly, 2.5 hours of outdoor activity. The life on earth is because of sun, and if you try to shy away from sun, you're missing on a lot of things. So the importance of sunlight and day-to-day activities outdoors is most important. Minimum 2.5 hours of outdoor activity is what research have shown us. Posture also has a lot of things to do with, the body posture has to be right. The distance of reading, writing material, about 36 centimeters. The surrounding light, indoor lighting. See, previously we used to have a lot of light falling on the papers or the books. Now it is emitting from the tablets or mobile phones. So the dynamics have changed. The previous speaker has spoken about the pupil dilatation, etc. So this is going to make a lot of difference in when you have a self-illuminating objects, the pupil constricts. And when you have a constricted pupil, the peripheral retina doesn't get enough stimulus. And that is one of the reason this child gets more and more myopia. Of course, the foods, the red, the white bread is not good for the high health in general, and fries. So think sensibly and use what you are feeding your children. So bifocal, progressive, 360-degree digital glasses, which are coming up in the market, is your choice. Multifocal soft contact lenses is the best. Orthokeratology, I love it. Low dose atropine is combined with any of these above treatments is again going to work faster and better. I particularly love orthokeratology because the child is wearing that lens when he's sleeping and he's under your control in home. When he goes out, there is nothing on the eye. He's just absolutely fine. So that boosts his confidence. He gets a natural vision, and there is nothing that stops from doing anything. So of course you have to consider what you're comfortable with. Again, 2.5 hours of outdoor time, green, fresh and uncooked or unprocessed food, posture, indoor lightings, and close work and timing is important. So children are our future. The eye care practitioner has a responsibility to educate the parents and offer options for myopia control progression to decrease the eye morbidities in the future. These are my references. Thank you very much. If you have any questions, I'll be happy to answer.
Thank you so much, Dr. Chawan. That was a wonderful presentation. Dr. Chandrasekhar has also given you the email address in the chat section, so you can contact him there if you have any queries or if you want to ask him anything. So that was, again, indeed a wonderful presentation from Dr. Chandrasekhar, and I'm sure our audience had a great learning experience from it. And we had a bit of issues before due to our technical problems, but all in all, it was a wonderful session. And once again, thank you, Dr. Chandrasekhar, for giving us your valuable time and being with us. So we've come around the end of our session today, and from the team of Mero Eye Foundation, I'd like to express our heartfelt gratitude to all of the speakers that were present, as well as our attendees who have been with us from the morning. And we've officially come to the end of the segment, and this is Manoj Fikarki, and I'd like to tell you that we have more programs lined up tomorrow and day after tomorrow as well. I believe Dr. Chandrasekhar also is going to present something else tomorrow. Am I right? Yes. So we have many presentations lined up. This is just day one, and we begin the conference tomorrow at 10 a.m. Nepal time, beginning with research updates by esteemed speakers, and we move forward after that with investigative optometry, pediatric optometry, and advanced contact lens practice. So I request all the attendees to join us tomorrow at 10 a.m. sharp. With that, I'm Anushvi Karki. I'm signing off. Have a good day. Take care, and I'll see you tomorrow at 10 a.m. sharp Nepal time.